All right, let's respect everyone's time, and it looks like almost pretty much everyone's here. Maximum will send the recording afterwards. So again, we're extremely grateful that everyone took the time to join us, especially after the last 9 or so months that of everything that we've experienced here in Israel. The sole purpose of this webinar, firstly, we're going to try to be as accurate with our time as possible, but the sole purpose of this is just to introduce this treatment, which we've been using now for the last few years here in Israel, but it's been around for many, many years before that. And again, for people who've just joined, there's a chat box where you can ask questions along the way, and we will answer them as we go along. So Golan, let's get started. Just with us today is Golan, our head of operations at Stellar. We have Tal Hartuv. My name's Jason Blankfield. I was lucky enough to come across this treatment in 2021, and I decided to bring it to Israel. So I'll be speaking a little bit today about the treatment itself, our data, and some of the important points that people should know about the SGB. We got Dr. Jason Cohen, who's a pain specialist and anesthesiologist, expert in the SGB treatment, specifically for PTSD and anxiety. Dr. Alan Flashman is with us. He'll be talking from his years of experience in trauma, and also from the last, wow, it's probably almost been a year that we've been working on this together. So the patients that he's treated pre and post SGB and how he uses it today. And lastly, we've got one of the most special and incredible human beings I've ever met, Tal Hartuv, who will talk a little bit about her personal experiences and kind of bring this all together. So again, feel free to ask questions along the way. And Golan, let's get started. So first and foremost, again, the mission of Stellar and what we're doing is we're trying to bring innovative treatments for PTSD and anxiety that don't really exist here in Israel or are a little newer to the environment. We're looking at biological interventions or physiological interventions that aren't necessarily medication. And the SGB, which we'll be talking about today and introducing, one of the things that is very important for me to say is that it's not meant to be a standalone treatment. It is for very rare cases, but 99% of the cases, this is a treatment that is then combined with ongoing therapy, psychiatric or psychological treatment. Again, this has been around since 2021. We have all of the accreditations from the Ministry of Health. We currently do this treatment off-label. It's under something called 29 Aleph or 29A, which basically means that this treatment has been around for over 100 years for chronic pain. For the last 20 years, we've seen significant advancements in this treatment for anxiety and for PTSD, specifically in the US. And so because we use it for the indication of trauma, it is off-label. But again, this is the same treatment, the same anesthetic that's used is FDA approved for chronic pain. One of the most significant things that's happened actually last week is I got a message from Professor Eyal Fruchter, who's head of the Advisory Council of PTSD in Israel. And after a long 2 years of trying to get this approved in the Ministry of Defense, they finally accredited the treatment. It is on the same lines as medicinal cannabis, meaning that it's a third-line treatment where you do have to go through 2 pharmaceutical medications and the normal psychological treatments. But if for any reason that doesn't work, then you are now eligible to get the SGB treatment under the Ministry of Defense and Ministry of Health. One of the biggest things as well that's happened, obviously, is the 7th of October. We've found that there are tons of people who are looking for other options, especially those who have tried several options and they haven't worked for them. And so we've seen a significant increase as people start to learn about this treatment and hear about our work here. And just the last few points. Like I said, this is administered under the Ministry of Health here in Israel. We have, for the indication or for the diagnosis, if someone is diagnosed with PTSD or general anxiety disorder, we are able to treat them currently under that 29 Aleph. If they don't have those diagnoses, we take them through a different process where we either connect them with Dr. Flashman or someone else, where they can get the diagnosis necessary for them to receive the treatment. We've done over 400 treatments over the last, the majority of them have been in the last year. And we have 2 state-of-the-art locations, one in Haifa, which is the Lisha Hospital, and the second in Ramat HaChayal, which is Medical Center. And just for one last thing of context, in terms of the safety and efficacy, in the US, the Veterans Association sees this treatment as a first and second line treatment, which they give to all of their veterans, or all of their veterans are allowed to undergo the treatment. I spoke to a social worker in Fort Bragg's, one of the biggest, if not the biggest army bases in the world. I think they have about 50,000 people there. And he himself, as one person, sent over 1,200 people to get the SGB done last year. So this is very well known in the US, and slowly but surely it's growing here in Israel. And because of the challenges that we had to get the Ministry of Health and the Ministry of Defense on board, and we had to do a lot of work to collect the data and to show them that this is safe and effective. On the side, we were able to raise over 2 million shekels in philanthropic money so that we could subsidize these treatments. For example, all Nova survivors we treat for free. People that have been through terror attacks or through Miluimnikim, we give them a significant subsidy. So we can talk about that a little later. But it's been significant that we've been able to raise over 2 million shekels to help those in need. So I'm going to cover very briefly the concept behind the treatment. So the stellate ganglion block is an injection of a small amount of anesthetic into the ganglion nerve in the neck. Dr. Cohen will speak more about that. We start on the right side, followed by 1 to 2 weeks later, a second treatment on the left side. The treatment itself is done under ultrasound guidance. That's one of the reasons why it's one of the more safe medical procedures out there, because Dr. Cohen or any doctor that performs this can see the needle throughout the entire process. The actual time of the whole procedure usually takes plus or minus 20 minutes. The injection itself will take anywhere between 4 to 7 minutes, most likely. And the risks and the side effects are usually at the time of the treatment or 8 to 12 hours post. They then disappear, and the treatment usually either works for the individual or for a small percentage, it doesn't work for them. Like I said before, the treatment itself has been around for over 100 years. The SGB is FDA approved. The anesthesia that we use is FDA approved for chronic pain. And because we're using it for the same locations, the same medication, because we're using it for PTSD and anxiety, it's used off-label. So what's the actual system behind all of this? The SGB is meant to act as a catalyst. It's meant to act as a restart for people who are suffering from physiological and biological changes due to trauma. There is a huge body of science that has gone away slightly from looking at trauma as just a psychological disorder. And we now see that there are significant changes in people's biology and physiology. And therefore, to just treat this as a disorder, in our point of view, is incorrect, because when your body is on fire, if you take your computer, for example, and the computer gets stuck, just as the body, for someone who's gone through a traumatic event, can get stuck in sympathetic overdrive, in fight or flight, the one thing that you need to do before you start anything else, before you start making order and structure around things, is you need to restart it. So the concept behind the SGB is to restart the sympathetic loop, and in many cases, we see that there's a significant decrease in people's hypervigilance, their increase in their ability to sleep, irritability, panic attacks, intrusive thoughts, and things like that. We see those either decrease partially or in some cases decrease very, very significantly. So we look at this treatment. When we talk about this treatment, we don't have to go into the patient's history of trauma, whether it's complex PTSD, if there's such a difference in a thing. Maybe Dr. Flashman can talk about that. But we look at what symptoms are they suffering from. If it's connected to sympathetic overdrive, we usually say this could be, as long as they healthy and that Dr. Cohen gives the all clear on the medical side, we can say, let's use this as a catalyst to restart their system. Let's then reintroduce or continue to go through the psychological and psychiatric care. And we've seen that people are making significant improvement as time goes along. The duration of this treatment usually lasts for anywhere between a few months to a few years. A little bit about our data, and I'll send this in an email, so I'll be very brief. So out of the 125 people in this data set, we use the PCL questionnaire, which is very well known today. Plus minus a change in 10 points is clinically significant. You see that after the first treatment on only the right side, there's an approximately, out of the 125 people, there's approximately a 14-point change. And as time goes along, after they do the second side, 1 month, 3 months, and 6 months, it climbs up to, on average, usually about a 25-point change in their PCL questionnaire. This slide, I'm just going to go over very briefly. You can see that the reason why I brought this up is that this has been researched since 1926, specifically for the safety and efficacy. And until today, it's being researched. I can think of 4 or 5 major research kind of trials going on as we speak in New York University and a range of other universities in the US. But I'll just focus on 3 very quickly. The first one is a crucial one, which was in 2019. This was done on a military base, and it was done with 190 people. And it showed the difference between the SGB for a placebo group and the people who got the actual SGB treatment, so a double-blind placebo study. And it showed that the SGB was double as effective as the placebo treatment was. In 2022, Dr. Eugene Lipov, the Chief Medical Officer of Stellate US, he did a research with 327 people, which they showed an over 80% improvement in their PCL scores during the treatment post-SGB. And one other recent one was in 2023 with 200 out of 265 people showed 75.5% of them showed a significant decrease in their anxiety symptoms following a GAD test. So we're starting to see that the research in the US that's been going on for the last 2 decades is pretty much in line or parallel, plus or minus, with what we're seeing here in Israel as well. And I think that we'll let Dr. Cohen take it from here.
Yes, thank you, and welcome everyone. So let's start briefly discussing the history of the SGB, which stands for stellate ganglion block. The SGB really dates back a good 100 years to the early 1920s, where we first learned its use, its utility in treating circulatory disorders and certain pain syndromes involving cardiac pain. In 2008, that was the first case series presented by Dr. Lipov, the Chief Medical Officer of Stellate in the US. Since 2010, a good 15, 16 years now, its application has grown and it's been expanded to treating anxiety and PTSD. So let's discuss what is this DSR, dual sympathetic reset. As has already been discussed, we have a sympathetic nervous system that runs along the cervical spine on both sides of the neck. This DSR refers to resetting the sympathetic ganglia. Ganglia, of course, being a cluster of nerves found in the neck responsible for this fight or flight effect, which is governed by the sympathetic nervous system. For many people, any stressful or traumatic experience can cause this fight or flight nervous system to get stuck in a sustained and elevated state. And to extract from that, we temporarily turn these nerves off, these bundles of nerves, ganglia, and it's understood that parts of the brain that control this fight or flight response are then allowed to restore and reset itself, thereby providing clinically significant relief of both anxiety and PTSD. So this slide kind of depicts the three cervical ganglia. Cervical is the neck spine, and we have the inferior, the lowest at approximately C8, the middle at approximately C6, and the superior, the largest of them all, running from C2, C3, and C4. So our block entails placing local anesthetic at two of these levels. We address the middle cervical ganglion at C6 and the superior cervical ganglion at C4. Now, this again is a brief description overview of the autonomic nervous system, which governs our body and provides a state of homeostasis on a second to second, minute to minute basis. It's kind of like a yin and a yang between the sympathetic and the parasympathetic system. Parasympathetic, of course, governs our heart rate, our breathing, our respiratory rate, the digestion. But again, anyone that is in a fight or flight situation for survival, the sympathetic system overtakes, and therefore you feel all the symptoms that you and your clients suffer from, such as increased heart rate, all along the right side, dilated pupils, we see increased salivation. All of these are direct impacts of a elevated sympathetic drive. Discussing now exactly how we do it, you see here in the picture myself along with Dr. Lipov identifying the target on ultrasound. This procedure is done under sterile technique in the procedure room under direct visualization of ultrasound, which provides optimal safety as you can visualize all adjacent relevant anatomy, not appreciated on fluoroscopy. Fluoroscopy is live X-ray. This is also done under CT. However, those windows provide what's called bony windows, not allowing us to appreciate the soft tissue, blood vessels, other nerves, and other relevant anatomy. Further, ultrasound guidance is non-radiating, so there's no exposure to any radiation as there is in other modalities. Here again, we have the comparison on the left side, a trauma state, and on the right side, a non-trauma state. If you focus in towards the top, the brain, the center where all of this sympathetic drive exerts its effect is in the amygdala. And you see the ganglia and the nerves running from the cervical spine deep into the recess of the brain, the amygdala, where it relays the specific neurotransmitter noradrenaline or epinephrine. Now, the ganglia themselves are factories for producing this, and then they also send directly to the amygdala, and it becomes a whole circuit, a whole loop. So if you now look at the right side of the screen, you'll see the two syringes, the two local anesthetic being deposited by the middle and the superior cervical ganglia, which then temporarily shuts off the ganglia from both producing the adrenaline and from relaying it along the course of the nerve roots deep into the brain to the amygdala.
Hang on, Doc Flashman, you're on mute.
Hello, I'm not now. My name is Alan Flashman. I'm a pediatrician, psychiatrist, and child psychiatrist working in Beersheba for the last little over 40 years. And I'll pick up on this business about the loop. You know, Freud was the first one at the end of what was called the Great War, when people started to notice the huge amounts of post-trauma. And Freud said that, you know, there seems to be a loop, but there was a neurologist, but at the time, one thought about a loop within the brain. Some things just didn't stick to anything, just had its independent life. And of course, Freud said it's a strange life because it doesn't stick. You can't talk to it. You can't do anything with it because it doesn't stick to thinking, to memories, to thought processes. And so he said more or less, I don't know how to treat it. It's not treatable with psychoanalysis. We now see it as a loop, but a loop between the brain and the body. And so it's the amygdala or other parts of the brain Neurologists love to think that they know how to localize things. Brain science suggests that localization is a bit of an illusion, but for now, we'll call it a localization. And the neuroscientists love to think that it's always one one transmitter. It's never one transmitter because there are 40 or 80 transmitters, and it's a balance between them. But whoever studies the balance, nature is made in balance. We don't study it, so it's an idea. We don't have to worry about it too much. The main thing is that it works like a loop. In other words, that when you have hyperactivation in the brain, it hyperactivates the body, the sympathetic nervous system, which then goes back and makes the brain excited, which makes and you get a loop. And the whole idea of the reset is that this is not a normal loop. In other words, our bodies are not set up to create that kind of a loop. They get created at abnormal situations that are panic, of extreme fear, what we would call trauma, an insult. So when you have this abnormal situation, you create a loop, but a loop is a loop. It keeps looping. And the idea that I think is useful for clients to think about, after all, I'm not a neurologist or a brain scientist, though I read some of it, but I do talk to people, and it's useful for them to know how to think about things. So we think about it as that your brain is stimulating your body, which is stimulating your brain. And if we can break that loop, it will settle down because it's not going to come back. It's not something that your body will create if you're doing better now, if you're not in a situation of trauma. So that's how we think about it. I think it's a useful way to talk with people about it. What's extraordinary about this treatment, which I've been involved with now for about a year, and it's been a great privilege, is that there's an immediate effect. In other words, when you start to deal with most of the talking therapies of one sort or another, except for some claims that are a little hard to believe, it takes time. And not every client has time, and not every client is able to handle the talking, because as you talk about what happened to you, you recreate the loop, and so it doesn't make you better; it makes you worse. And so sometimes you have people go for a session or two and freak out and leave. It's not uncommon. So with all respect to the people who can make use of the talking therapies, not everybody can. I think that that's a clinical finding that we have to accept. Whereas here, you don't really have to do anything. You have to not freak out about an injection in the neck. And that's something that we try to help people with because, you know, if you say, well, we're just going to do the small injection in the neck, the average client thinks this big, this thing stuck in the neck. So we help them to understand that it's more or less like starting an IV. It's under the skin. It's very gentle. You don't feel very much, and it's very, very safe and regulated. But they have to go through understanding that it's not going to change very much. The immediate effects are terribly important because for many of the people, even if it's a partial effect after the first injection, it restores hope. Because the one thing that this loop creates is despair. In other words, the person feels that they've been traumatized and they seem to keep traumatizing themselves. Well, they're not exactly traumatizing themselves, but it sure feels that way. That's what made Freud say, I can't explain it because according to the pleasure principle, whatever really traumatized you, you should forget immediately. Why do you keep remembering it, right? And so it seems to work on uh, um, a different organization. And when a person feels some relief, it gives them hope that this is a treatment, this is something that can be treated. A lot of times then they're able to participate better in the talking therapies. The things that we see that are terribly important to begin with is, first of all, sleep is often restored because, people who work with emotional problems know that sleep is a very sensitive indicator to stress. And most people with post-trauma have horrible sleep. And that gets them into another loop, which is they're always exhausted and they can't think and they can't quite concentrate and function. And when they finally have a good night's sleep, it restores both a certain balance and a certain amount of hope. Um, it has an immediate effect on the feeling of tension. What's written here is stress. What we mean is that the people with post-trauma have this sense that there's like a spring that's taut, and I can't do anything. It just keeps, jittering. And so that sense of tension bedevils them. They can't sleep, they can't think, they can't concentrate, and so forth. And many times the immediate effect, even if it's partial, is one of there's less tension. The world isn't attacking me. Something can, sometimes you talk to people with post-trauma and you see that for an hour they're like this. They don't relax. And after that, you can see that they can relax, they can be more themselves and start to laugh a little more. And it gives them more hope. And what's extraordinarily useful for this treatment is, that a lot of times your closest relationships are kind of being traumatized with you because you're really pretty impossible. And when you bark at everybody and you can't take it, you're just a total frenzied mess. So is everybody else who loves you. And so sometimes it'll be a spouse or a child who will notice first that there's a relaxation because they feel the environment is becoming better. And one of the terrible tragedies of post-trauma is that it traumatizes people around them. When I was working with medical cannabis for post-trauma, I actually treated a father. This woman brought in her father and said, look, he was messed up in 1973 in the Yom Kippur War. And he got somewhat better with medical cannabis. And then she said, by the way, he messed me up because he was barking at me. Can I have it too? And so we may see two generations of SGB as we've seen sometimes with cannabis. Now, when you restore hope to people, they want to be themselves. They want to be back to who I was before this happened, who I can be. And one of the important parts of this particular treatment is that it doesn't affect who you are. It's you can think of a reset that way because it doesn't change your sense of who you are the way all of the medications do in some way or other. Um, and here, there's no change in emotion or cognition. And so whatever you get, you own it. It's yours. It belongs to you. It doesn't belong to that drug. And now what? I'm supposed to take this the rest of my life? And that's an advantage that has over medical cannabis as well. Now, if we say, okay, this is one part of an armamentarium, it's part of what we can offer. And so we go back to the original point that I think anybody treating post-trauma knows that we don't have an exhaustive treatment for post-trauma. It's not as if you go and do this, it'll be fine. Or if you do that, it'll be fine. There are people for whom that's true, but there are many people who are not the case. And even if we weren't minded to populations before October 7th, we sure are now. And so we have populations, people who were traumatized at the party or in the Gaza border, and we have people who have been living outside of their homes for more than half a year, and we have all of their relations and people who are, just simply frightened. And so we have a huge population, which we do not have the mental health capacities in Israel to treat. The investment in mental health has been dwindling, even worse than the investment in medicine. And we don't have the capacity to treat many of those people. And so here we find a procedure that's easy to use and comes in at a point where it's awfully important for us to be able to use it. Sometimes I think it comes before the other therapies because, as I say, some people can't do the talking. It's not useful for them. It becomes possible only after the SGB. So sometimes I'll see somebody and say, look, when you told me about what happened to you, it didn't help you at all. It made it worse. Why don't you do the first injection, then come back and we'll start to talk? There are people who are in the middle of talking therapies. One person who I sent recently has been talking to me for 2 years about childhood trauma, did medical cannabis as well. But there was something that the SGB did in releasing that tension that nothing else did. And so his life gets back, and that's what he said. He said, this is me. The rest was close, but as we used to say, no cigar. And this is a cigar. This gives me, and Freud said sometimes a cigar is just a cigar. So this is me. This is who I really am. Medical cannabis has been extraordinarily useful when it was properly administered. And, you know, it's possible to get a license and to work with it. The administration of it at this moment, we're talking about after and during the war, the administration of medical cannabis is so problematic that it's even hard to get a license. It shouldn't be that way, but it's not a useful modality right now. But for the people who have had medical cannabis, that's how I got the Stella. I had a client who were doing endless talking and medical cannabis and medication from the Second Lebanon War. And he found out about Stella, went through it, had that special change that we weren't able to get to. And I found out about it. So I called and said, what on earth are you guys doing in the neck? Is this the head? They said, no, it's the neck. Okay. So we're learning from each other. And finally, it's worth remembering that, the last time there was this, just 2 years ago, there was a major study of what is the first line of medications for post-trauma. And some people made this little list, with an N this, but the results were horrible. And most people know that in post-trauma, the medications, the SSRIs, let alone, God forbid, the antipsychotics, they're just not precise. They're not for that. And I'll just add one last thing that I learned through medical cannabis was going to be true with Stella. If you have clients who seem to schlep along, they've tried this medication, that medication, they've even tried them at high doses, which not everybody does. They've really had a full trial. You can't get them free of their anxiety or free of their depression. Think that trauma is what is creating the affective instability. And most of the time you'll find the trauma. When I started to be minded to it, I found these traumas that people, post-trauma people avoid talking about trauma. So they said, look, I have depression. But when you have a new treatment for post-trauma and then you look for the trauma, well, surprisingly, you find it more than you might think. And then Stella would be a very important treatment. I don't think that the notion of third line is certainly not evidence-based. I think it's politically based. But, from my point of view, fine that somebody said that, but people need the treatment that they need to have. So I don't think anybody in his right mind would say you have to be on a medication for 6 months before you can try Stella. We'll find a way around that. We'll refer to those as exceptional cases. There are exceptions to every rule. In this case, there are exceptions that are longer than the rule. So if we come down to the simple question of what's worth trying, because in medicine, science, right? We hope science knows the past, not the future. And so when we say take Tylenol for a headache, we say that's worth trying. Whatever reasons, it has a good chance of helping, not a very big chance of hurting, worth trying. Well, when you deal with post-trauma, which is destroying people's lives, simply destroying people's lives and the lives of those around them, and especially now where we're in this situation, we have a huge crisis of post-trauma, and we don't have other tools to treat it. And then you would say to yourself, well, is this a, jab in the neck worth trying? It's not a jab in the neck. It's like starting an IV. It's in very good hands. It's very mild. It has a very, very significant chance of being the starter of a good treatment. And it has almost no chance of hurting anybody, except because people are afraid of needles. So from the point of view of a psychiatrist who works with medications, who works with medical cannabis, and who works all the time with talking therapies, I have to say that this is an enormous gift, an enormous blessing for the population in Israel, especially in this year. And I'm happy to participate in it.
Well, Flashman, just a quick question by Tzipora was, do the patients typically wean off their psychiatric medication after successful SGB treatments, or is there still usually a need for medication in your experience?
Usually they should have weaned off before because they weren't helping them. In medical cannabis, we already saw that most people weaned off SSRIs. SGB is too soon to see, and I'm hoping that we're going to do SGB more with people who don't have to wean off their medications. But if somebody's on a medication, just like with medical cannabis, I prefer to stay with the medication, do the SGB, and then do the weaning for the simple reason that weaning off of some SRIs is really difficult and creates an instability, and you don't want to be treating that instability. You want to do the SGB and then deal with the instability later. But my guess is that the weaning is probably easier after the SGB. That's a guess. It certainly is the case with medical cannabis. But I would hope that medications that were never really that helpful for post-trauma, most people will feel it's me now, it's not the medication.
Right. If I could add to that, I think this is a good time to restate and emphasize the utility of the DSR or the SGB, as Dr. Flashman has touched upon various classes of medication. Traditionally, patients would have taken or been prescribed benzodiazepines, which work on the GABA system, SNRIs, SSRIs working on the serotonin, etc. But what has been borne out through anecdotal evidence, but also through the research over the last 10, 15 years, is that PTSD is primarily a biophysical chemical manifestation issue, as we've discussed, this elevated sustained sympathetic overdrive. And that then manifests with secondary psychological symptoms, not the other way around.
No, I would agree with that. Well stated for a non-psychiatrist. Very good.
I'm going to now give the podium to Tal. Here's her book. She's an author. It's called The Rage Less Traveled. She's one of the most remarkable human beings that I've ever met, like I said. Tal was in a severe terror attack many years ago, which she'll maybe just touch on for a second. But she was unfortunately stabbed many times, broke 30 bones in her body, wasn't meant to survive the attack, walked, I think, over a mile, and somehow made it out alive. And she's got many interviews and things online, which I would recommend that you watch and you follow along for. The book is in many ways, very difficult to read because of the story, but also one of the most unbelievably and well-written books that I've read in many years. So Tal was our very first patient here in Israel. We've stayed friends ever since, probably because it helped a little bit as well, which was part of it. So Tal, please share whatever you feel is right for you to share, and we'll go from there. Golan, do you want to put her as
well? Thank you, Jason, and thank you, everybody. Shame I can't see your faces. So just to paint the picture black before we can paint it white, indeed, it's as Jason said, I was with a friend, and I just want to denote here that it was, you'll know as professionals, it was a complex pigua, terror attack, because there was being held at knife point for 30 minutes where your life's in the balance, and then being tied up and watching my friend hacked to death in front of my eyes before I myself was being stabbed multiple times, and then playing dead, getting back up to walk, got ribs coming out of me, my lungs collapsed, and I understood I'm going to die. So there was that long 30 minutes of coming to terms with that's it. The show won't go on. So that was the event itself. Now, it's been a long physical recovery too, but I want to touch on the psychological. I'll tell you the therapies I did and the therapies I didn't do, and then just add a little bit more. I did CBT in Hadassah Hospital. I remember getting there a few weeks after the attack, and I sat in this room with this religious lady. Nothing personal against the religious community. I'm not religious, and I just remember looking at her. She's 2 meters away on the other side of the world, thinking, my God, how are you going to help me? And she did something very smart. She told me on the first meeting, she said, this therapy will last 3 months. and you're going to feel worse before you feel better. Now, for me as a patient, to be told that there's a limit to therapy and that it's not going to go on and on and on and on, this was incredibly hopeful, just a little glimmer of hope, even in those dark moments. And she was right. I felt much worse before I felt better. Jason mentioned my book, part of the therapy, which it was to write the events. Now, I'd had the statement I'd given to the police, and it was very much, we did this, they did that, he took his knife. And so what she did in a very skilled manner, that first A4 page, I had to revisit every sentence. And for a couple of weeks, I had to write about what I saw, the tone, the movement, the color, like, what did I see? And then I did it with, what did I hear? To be specific, did Christine, my friend, did she scream or whimper or weep, or did they growl or gnarl? I mean, it was picky, cherry picking words. And in those long weeks of writing that, that's the worst I felt. Now, also with her, I did that with all the 5 senses. And then I did with her, how do you say, simultaneously, I did gradual exposure therapy. And because the attack happened in a forest, my homework, you know, you make the list of what the avoidance thing. And of course, for me, the worst thing was to go back to the murder site. So I started with I took a friend who had a gun, right? My Arab bus driver. I used to work as a tour guide. And I remember just staring at a tree for 10 seconds. And then the next week it would be 15. And after a period of time, I was back at the site. And I've been back a few times. Not of late, but that's just because we have a war going on. So those were the therapies I did. And then a few years later, I started getting many, and I don't know what caused it. I got a lot of flashbacks. Actually, it's not a flashback. I never had a flashback. I never, like you see in the movies or maybe with other patients, I never, you know, felt I was there back in the forest. I never had that. It was more like flash presence. Like I'd be in a situation and I found myself tensing up and I was nervous and I was sure that somebody was going to come and knife me in the back. It wasn't an anxiety attack. I never had an anxiety attack. It was just over stressful. By the way, I never had nightmares, ever. That's probably because I never really slept more than, I don't know, I don't want to exaggerate. It didn't feel like I slept more than an hour without waking up, and it was never a deep sleep. Actually, I did have a nightmare. The only nightmare I had is that I dreamt that what happened to me was only a dream. Like I woke up thinking, yay, it didn't really happen. And then I twist myself and, oh my gosh, that was such a cruel nightmare. But beyond that, I didn't have it. So to deal with these flashbacks, I did EMDR, and that really helped too. So we're talking about a gap. The attack happened at the end of 2010. And I think by the time I did the EMDR, it was 2016, something like that. And then I don't know what happened. I didn't want to do, and no disrespect to any therapists here, there were 2 routes I didn't want to take. One was meds. I really, from day one, I knew that I had to face this head on, whatever that means. I wanted to have all my, faculties about me. I didn't want meds. I did take sleeping pills. Of course, lots of whiskey and that kind of thing, but they didn't really help over time. And also, I didn't want to do talk therapy, meaning I personally didn't see the point. I needed to be pragmatic. I needed to know that therapy would last a particular amount of time. I have a goal, and this is what I'm going to do. So skip forward a few years. I made some changes before I did the SGB. I'd spoken all around the world about the funding of Palestinian terrorism. And what I found out while I was doing this, I mean, it gave me kind of an existential meaning to the meaningless of it all. But after a few years, I had this horrifying revelation, eureka moment that, you know, I didn't speak anywhere without getting an ovation, and people would hug me and they all mean well. But I realized that I was being congratulated for being stabbed almost. That's what it felt like. And that everything that had happened to me had become me. Now, I always insisted that people didn't call me a victim. I found that very humiliating. I wouldn't ever say I wasn't a victim of a terror attack, but to be in perpetual victimhood, to be shackled for helplessness was something I didn't want. So I'd introduce myself as a survivor of a terror attack. But I got to the point, and it was on the 10-year anniversary, that I thought, this is something that happened to me. It's not who I am. It's what happened to me. Meaning there's more to be me than being stabbed. And I did something pretty drastic, which I'd thought about, and I changed my name. I wanted to be anonymous. I stopped public speaking. I did some courses at Yad Vashem, became a guide for Yad Vashem, an educator. And of course, I'm well known, so it didn't really give me the anonymity. But by changing my name, I could tell people, listen, I've done it. I'm not there anymore. I want to do other things. So that was one thing. And then after that, I don't know how long, I did live in paradise for a while. And then the Dr. Allen said about it, like the sleep. And I found that, I can't remember what triggered it. I began to sleep very poorly. And when somebody sleeps badly, as Dr. Allen said, everything goes, you know, I don't know how to say it, like shit face. It just doesn't work. And I don't know how I got hold of Jason, but I was feeling very desperate because I felt I'd made so much progress. And then this lack of sleep, it really sent me on a downward spiral. And I say that because when Jason talked to me about the SGB, I think for people who are considering it, it really is a matter of how desperate you are. And I was desperate. And also, I mean, look, I've been hacked nearly to death with a machete. We're talking about a needle. So I didn't feel scared or anything, but I didn't feel especially hopeful. But I felt like I tried everything. And when I went to do the SGB, first of all, I was very well prepared. Like Jason had prepared me extremely well, what to expect. It was kind of like a lovely casual environment. There is the nerves, of course, like you're feeling a bit nervous about what's going on. But I tell you, that night after I had the first injection, I think Jason, not Dr. Jason, other Jason, you'll have to say what year it was, but it was the first time I'd really slept more than 3 hours in over a decade. And I slept 5 hours that night. And not only did I sleep 5 hours, I also had my first dream. Just a stupid dream. It wasn't a horrible dream. A white friend of mine gave birth to a black baby in the Yad Vashem car park. I mean, it was kind of a fun dream. But I woke up thinking, I just had a dream. I slept. And the hope that gave me was incredible. So, and then I had a few months later, I had the other side done. And I've got no fish to fry here. I'm not getting paid for this. I think this SGB has been the icing on the cake, whatever you want to say. But even since October the 7th, I've gone back to public speaking because I'm competent at that. And people say to me very kindly, like, oh, this must bring it all back. And although we're all collectively horrified, it hasn't brought it back. Not in the sense that I'm sleeping a bit less because we're at war, we're all anxious, but I'm not functioning on any lesser level. Now, one thing I do want to say, aside from SGB, because we've all spoken about treatments, I think with trauma, and I don't know, the doctors are here, like trauma doesn't change you. It exacerbates, as I see it, exacerbates both positive and negative characteristics. Like if you're a hypochondriac before trauma, let's say I wasn't, but let's say I was a hypochondriac, got a sore throat. After the murder, I'm sure I'd have pancreatic cancer, that kind of thing, that your negative traits are exacerbated. But I've also found so are my positive traits. And I've always been a person with a lot of interest. I read, I don't watch TV, I like bird watching, photography, music. You know, who I am, aside from the treatments I've received, that sustained me. And I've always had very dear and good friends, and they were magnificent. One thing I didn't have, which is what we have now, and the soldiers also have it, is, I don't know how to say it in English, like gibush. Sorry, you're going to have to throw in the word.
Togetherness, like, something like that.
Yeah, like the army, when soldiers go to war, they're in a unit, they're in it together. And I see it with the people from the South, all right, where these atrocities took place. Even though their lives have been shattered, but they're together. And this together, this community is huge. And I think part of it is that somebody bore witness to what happened to you. And I didn't have that. And that was incredibly difficult for me. So I'm only saying that because if you as professionals are dealing with people who are suffering today from the recent events, then I think this idea of gibush is extremely helpful. So the thing is, aside from the treatments, I had to reinvent myself. I changed my name. I went from being victim to survivor to just Tal, you know, and if somebody asked me to introduce myself, there was a need in the beginning to like vomit out everything that happened. But that I'm saying that because there's no substitute for time. I don't know that we can rush incredible trauma. For me, I needed that time along with the different therapists. And I think only the thing that triggers me now, and I don't know if it's just because it's Israel or because I had so much problems with the bureaucracy in Israel with Bituach Leumi and everything. The thing that I don't cope well with now is not the alarms or the anxiety of the war. It's still this paperwork, it's bureaucracy. That's when I feel like I'm melting down. So although I'm the same person, I think trauma changed me for good and for bad. So that's all I want to say. I think it's not just dependent on therapy. As professionals, like it's in a digital world where everyone's on their phone. I mean, great, be on the phone, but there's something about having a healthy mental life aside from the trauma, and a physical life, and taking 5 minutes to go out and listen to a bird singing. Like these things, they're not medicinal, but they really help me. And even establishing, Jason and I always talk about this, like routine. Now, I'm not like the Gestapo routine. And, you know, when you don't have sleep, there's no routine. But I had to start routine. And that meant having a cup of coffee and a cigarette every time, whether I'm awake or asleep. I'm going to get up and have that cigarette. Sorry, coffee. Or, you know, and I start with the small routines. And like to build a routine is very, very healthy. And just to say that today, even I've seen the most terrible things, and something about it will always be a little bit unbelievable. I'm today translating testimonies of October the 7th, and I think a lot of that is not just due to the treatments I've received, and especially the injection. It's also because of who I am, and it's that combination. And I had a very good supportive friends. So thanks.
I'll just add, Tal, you can just continue this for a minute or so, but you're actually one of a number of people. We have no data on this clinical trials, but I know that you stopped drinking significantly. I don't know if you're still having a couple of schnapps these days, but for the year or so after the treatment, I know that you stopped, you stopped drinking. We've had a number of people that have stopped their alcohol consumption post or decrease their medical cannabis, which they wanted to decrease before the treatment, but they didn't feel like they had it within them. So if you can touch on any of those changes as well. And
yeah, I mean, I did drink a lot. In fact, I don't know why I didn't buy shares in Johnny Walker or something. It was really not very bright. I mean, look, I'm from Britain. It's a drinking culture, but I never like it wasn't a drunkard. Like, be used to having a drink as a Brit sometimes, but I drank. I didn't drink because I was depressed. Incidentally, I never recall feeling depressed. I felt maybe it is depressed, just felt very numb. Oh, and remind me about the nummy. And then after the, what do you call it, the injection, Jason's absolutely right. In fact, I'd cut down on the drinking way before, but there was always that, like, I might as well have a drink type thing, which I didn't like, but always gave into. But I think since the injection a few years ago, I mean, I'll drink wine with friends, but I can appreciate it. You know, I'm no Mother Teresa, and I don't want to be. I mean, I still smoke. I like having a cigarette. I like having a glass of wine. So I feel like I have a very moderate approach to these things. One other thing, Jason, you'll remember this, and this was a breakthrough with the SGB. It so happened that the appointment for the SGB coincided in the same week. I'm suing the Palestinian Authority basically for the funding of terrorism, and I had to be evaluated by a Jewish psychiatrist who's working for the Palestinian Authority. All right, she's been employed by them. We won't even go in there, but when I was going to be evaluated, I felt so angry with her, like, you know, such a capo and all this. And I'd had the injection a couple of days before. That's what I want to tell you. And then I get into this meeting, and she says, okay, tell me, like, she almost sighs, like, okay, tell me about the Pigor, tell me about the terror attack. And I felt, I just don't know, since that injection, I felt something brimming, you know, there was a volcano. And I hadn't cried since I was attacked. I couldn't cry. The only time I cried was when my dog died, the doggy who was with me on the attack. I couldn't cry about Christine. It was too big. But in that evaluation with the psychiatrist, I tell you what, I hope this doesn't go outside of Zoom. I had a total meltdown. I was crying out of rage and anger. I was drooling. I was calling every word that I never used, and most of them I never used before. I spat on the desk. I mean, I literally lost it. And I came out of that meeting, and the next day I called Jason. I said, listen, I feel, I don't know, this is what happened. And Jason said to me, he said, this is amazing. Think about it. How do you feel? And I felt great. I mean, I felt a little embarrassed that I lost it, but something about that block opened the floodgates of the rage, which I knew was inside. And that's why Jason plugged the book, The Rage Less Traveled. But I just felt cleaner emotionally. So yeah, drinking is like, yeah, I enjoy it. I don't want to stop having wine. I like it. It's nice. Yeah. And I feel like that my anger, apart from bureaucracy, where I don't curse people, I just don't do it. I just won't manage with it, so I'll ask for help. But I think that my life is inherently much more higher quality since I've had this injection.
So Tzipora asked, do the patients typically need more than one treatment, or does one intervention cure post-trauma? I think one thing that we can say with Tal is that Tal had the right side and left side done. And then approximately, I think 1 year almost to the day since the treatment, Tal came in for a third maintenance treatment. It is something that, contradictory to a lot of the other medications that you need to take daily, we try to treat people as little as possible. We try to give them as much time as possible. However, we have found that if this treatment is successful for them, people who do come back for a maintenance treatment, according to our data, have had the same, if not a better, reaction to a third treatment. So we usually do right side, left side, wait as long as possible. If they do come back, we repeat the block on just one side. And again, we wait. But what we've seen is that people usually feel the same amount, if not more, of a relief than they did in the first two. Just two quick things, because I know we're at an hour, but Dr. Flashman, for you, Joseph asked, after treatments, do clients have a need to continue in psychotherapy or other treatments, EMDR? Or for those that were unable to make significant progress in the treatments prior to SGB, are they then able to make more significant progress in therapy?
Well, it's a very good question, and I can talk about the limited experience that we've had, but that's the experience we have. I would say that overall, it makes the psychotherapy more possible. Most of the experiences that I've had are people who were still stuck in avoidance, and they became freer. You know, not necessarily a meltdown like Tal just described, but not everybody has trauma like that, but freer to be able to talk about it, to go through it, to do the prolonged exposure. Um, there are people who feel okay, and those people, it's too soon to say. My guess is they'll feel the right time. Tal mentioned the fact people need time. That's how people are. So some of them, I think, will come for treatment the year afterwards, but it isn't the year afterwards. So I don't really know. But certainly some people have made significant use of therapy they weren't able to do before.
And one more, what about clients who have anxiety and PTSD, complex PTSD, but want to stay in victimhood from your experience with this?
Right. People who want to stay in victimhood, I know who asked that question. Hello, Maria. That's very complex because, you know, no physical symptom, no physical treatment is going to change your attitude about things. However, my guess is that it actually does change your attitude, because I think that when you say somebody wants to stay in victimhood, it's more a statement of the fact that they've given up on ever getting out of victimhood. So instead of feeling that it's forced on them, they take it on themselves. That's a sort of a mechanism that happens with identification with aggressors and things like that. But my guess is that what we'll start to see, but it will take time, is that somebody starts to feel that the victimhood is less fixed, that it's possible to feel experiences that aren't like victims. Sometimes the therapy doesn't deal with the trauma. It deals with like the life that you didn't have when you were busy being a victim. And you start to talk about things that you like to do, movies that you like, you know, people that you like to see. And somehow your life starts to open up because it's possible now. It wasn't possible before. And then you can say, it's sort of like, you know, a minor adaptation of what Tal did. You know, you say, in the Hebrew, we say, that's not who I have to be. I don't have to be only a victim. If I get in touch with the me who's not always looping, I can feel something else. And then the person, you can talk to them about transforming it. So I wouldn't say that we're limited from it, but it's definitely going to be a complex process.
And for Doc Cohen and Doc Flashman, has it been tried on people with chronic fatigue syndrome and fibromyalgia, having paradoxical reactions to drugs and food supplements?
I don't recall any of our patients suffering from fibromyalgia, aside from one or two. And I believe that they were recent. So I think we're still unsure of the data of the response.
I would speculate, but take it for as a speculation of somebody old. Old people get to speculate that call it experience, you know. But the speculation is that a lot of fibromyalgia is that tension that turns into a pain syndrome. And so one of the things we hope we can maybe prevent is this development of fibromyalgia. And we've had some people who seem to be on the way to it. If they seem to be on the way to it, a lot of times when they feel less physical tension, they say, and the pain seems to be gone. So that would be wonderful if that turns out. I think that we had one client who I encouraged to come, who has, I don't know what he has actually, but it's some sort of complex mess where he didn't get any relief from the pain or from the pressure or from me. And, you know, it happens. It didn't make him worse, but we didn't seem to be able to make progress with him. That was one case.
Al, did you want to say something?
Yeah, sorry to go back. Just that somebody asked a question about victimhood, and Dr. Allen referenced that too. But I just want to bring up one incident. You know, I was like 3 years on my back. I'm single. I needed help to get up, get dressed, go to the bathroom. It was also shaming to do everything. And of course, the PTSD was off the charts. And I remember a friend of mine, a single mom, who'd come every day. She had a little kid. And I'm so sensitive to noise, right? And the kid was going, eh. So I yelled at the kid. And my friend, it's very early on after the attack, she came up to me and she said, I love you, but you will never shout at my child like that again. And it threw me out of the ballpark. And to this day, I will kiss her feet. Because, sorry about the poor metaphor, I could have got away with murder. I mean, I did, and I felt I could again. But that love, that honor, that accountability I still had to the other, despite what I'd been through, that was one of the most liberating moments, very, very early on in trauma. So I just, if you're professionals, caregivers, the metupal, the what do you say, the client, whatever, nobody is so helpless that they can just let it all hang out. There must be accountability, and that accountability, it really saved my life. It really did.
We're very lucky that for people who are nervous about the treatment or want more information, very specific people, we connect with Tal, and good luck to them, because when they go into a victimhood and Tal tells her story, very often they snap out of it. So we're very appreciative that you're on the team, and that you're with us on this journey. So we're a couple of minutes over, but I just want to thank everyone again. I think we've answered all the questions that have been posed thus far. We will send out an email with our website and phone number. Golan, can you bring up awesome. So if someone wants to take a quick picture of the screen, that's the website, that's the phone number. That phone number also works on WhatsApp. And you can obviously reach out to me personally. So we really appreciate everyone taking the time again. And we hope that we can, at the end of the day, this treatment is, like we said, it's not a standalone treatment. Without people like yourselves who have joined, this treatment won't be nearly as successful as what it can be. So we're open to all different ideas, research, joint ventures, but mainly there's a lot of people who need a lot of help, and we want to be a part of the solution to getting them that help and that relief. So thank you again, and hopefully we invite you to come and watch the treatments whenever you can. So thank you.